presentation be done by Dr. Gregg W. Peri-infarct zone pacing to prevent adverse left ventricular remodeling in patients with very large myocardial infarction. This is the PROM trial. Greg?
Thanks, Fausto. Good morning, everybody. It's a pleasure to report these data to you. So let me, before I talk about the design, let me give you a little bit of the rationale. As you saw from the first presentation in particular, patients with large myocardial infarction still have relatively high rates of mortality and development of heart failure. And one of the things that causes this, we believe, is that delayed contractility in the peri-infarct zone area leads to increased stroke work and increased wall thinning, expansion, left ventricular aneurysm formation, and heart failure. So it's left ventricular expansion, and this actually worsens the prognosis of patients with large myocardial infarction. A prior study called the MEND-MI study hypothesized that peri-infarct pacing, putting a left ventricular lead in the peri-infarct zone pacing, would, if you will, coordinate the left ventricular contraction to decrease the wall stress in the peri-infarct zone and therefore decrease left ventricular remodeling and have a positive impact on prognosis. That was a small trial which was overall negative, but there were some positive secondary endpoints. So with this in mind, we designed the PROMPT trial. And in the PROMPT trial, we took 126 patients with a very large first myocardial infarction, defined as a CPK of greater than 3,000. And that's a parameter that's been strongly correlated with positive remodeling during follow-up. And specifically, a QRS duration of less than 120 milliseconds, so there was no indication for biventricular pacing, within 10 days of symptom onset. And all patients had a baseline two-dimensional echocardiogram, assessments of quality of life, et cetera. And then they were randomized 1:1:1 to either CRT-D in two of the groups. Both groups had biventricular leads placed, but in only one group was actually biventricular pacing performed. In the second group, the right ventricular pacing function was suppressed and left ventricular pacing was performed. And in both of those groups, the left ventricular lead was placed in the peri-infarct zone by 2D echo guidance. And the patients were blinded as to whether they were receiving single LV pacing or dual lead biventricular pacing. The control group had no implant performed and therefore was unblinded. We had multiple follow-up evaluations through 18 months, and at each of these follow-up evaluations, there was a repeat two-dimensional echocardiogram done, multiple quality of life assessments, and 6-minute walk test to determine exercise performance. This was the primary endpoint of the trial, which was the change in left ventricular end diastolic volume, that is, remodeling from baseline to 18-month follow-up, adjusted for any slight differences in baseline LVEDV. And you can see in the control group, the baseline increased from 118 cc's to 133 cc's, an adjusted change of 16 cc's. In the pooled pacing therapy groups, and the trial was powered to look at pooled pacing therapy versus the control, you can see the adjusted change was 16 cc's, so this difference was negligible, and there was no significant difference in the outcome. Looking at exercise performance with 6-minute walk time, there was somewhat improvement in exercise performance over the 18-month follow-up period in both groups, a little bit more numerically in the pooled pacing therapy group than control, so additional 22 meters of walk distance, but nowhere near statistically significant. And looking at multiple quality of life measures, such as improvements in the Minnesota Living with Heart Failure score or the EQ-5D, also no changes over time with peri-infarct pacing. And then finally, looking at composite endpoints such as death or heart failure hospitalization, you can see that over the 18-month follow-up, this was a high-risk patient population. The mean CPK was about 4,800, and you can see about 20% of the patients had an adverse event at 18 months, but the curves were once again superimposable, pacing versus control. So we concluded that in this present multi-center randomized trial, peri-infarct pacing did not prevent left ventricular remodeling or improve functional or clinical outcomes during 18 months of follow-up in patients with a large first MI and a normal QRS duration.
Thank you very much. We open for questions now. Any question to Dr. Stone? Please.
Just a quick one. Was there any difference between the biventricular pacing and the LV pacing only?
Yeah, great question. You actually may want to know why we did both leads. In the prior trial, they only did biventricular pacing, and there's actually some data that biventricular pacing in patients with a normal QRS duration can actually worsen dyssynchrony and actually interfere with left ventricular efficiency. So we actually looked at single LV lead pacing as well. So there was no significant differences in the primary endpoint of left ventricular end diastolic volume. Again, the curves were almost superimposable with all three groups. The only one difference was in 6-minute walk time difference, where there was an improvement with single LV lead pacing, where there was not with biventricular LV pacing. But we looked at so many different endpoints and so many different subgroups, I think we've got to very cautiously interpret that.
Please go ahead, ma'am.
Hi, I'm Peggy Peck, MedPage Today. So the question, this trial and then the earlier Circus trial, two trials that, that proceeded after initial small trials gave some sense that there was a benefit, not an overwhelming sense, but some sense, and then moving to a larger trial. And I've had several people comment to me that maybe we need to look at the way we design trials, because we do a lot of phase 2 trials that give a hint of promise and then move on. In other words, there's so much enthusiasm about a hint of promise. You've done a lot of trials, so I'd like to get your sense of, do you think that it's time to rethink the process and that we need a stronger signal early on before proceeding?
Yeah, it's a great question. It's a difficult question. I mean, large myocardial infarction, once the horse is out of the barn, is a very difficult area to try to improve upon. And there are many possible approaches that are still being looked at, from cell therapy to ventricular partitioning devices to supersaturated oxygen, so there are many hopes. But I guess the question is the clinical enterprise system basically at fault for not identifying the right kinds of patients? I think there is a limited window, as Michelle had said before, and there are only a certain time period where we can actually impact left ventricular function. Many of these patients present too late to us, and so we don't have a great opportunity to intervene. I think that, you know, short of large outcomes trials, I mean, it took 3 years to enroll these patients, 126 patients with these large infarcts. So the good news is that I do think heart failure overall is decreasing, because we've gotten very good with primary angioplasty and early reperfusion. But I think the problem is when you try to get too specific and really narrow the type of patient you're going to enroll, you can never find that number of patients. So bottom line is I do think there's going to be some role for large, simple registries or very large, simple randomized trials looking primarily at mortality, very different than the way we're doing it today, but I don't have any fast, simple, rapid answers for you.
Any other questions? Okay.